Welcome to the Lymphoma Research Foundation's update on immunotherapy in the treatment of lymphoma webinar. My name is Shalane, and I'll be the moderator for today's call. During today's call, you'll hear from an expert speaker, and you'll have an opportunity to ask questions. If you have any questions during today's presentation, you can ask them at any time in the Q&A box on the webinar. As a reminder, this webinar is being recorded. At the end of the program, a link will appear on your screen. Please follow this link to complete an evaluation of this program and gain certification of attendance. If you are listening by phone, this link will be sent to your email at the end of the webinar. And now I'm pleased to introduce Cecilia Bosco. Cecilia Bosco is the Program Manager of Patient Education at the Lymphoma Research Foundation. Welcome, Cecilia.
Thank you. And thank you to each of you for taking the time to join us on today's update on immunotherapy in the treatment of lymphoma webinar. We'd like to thank our sponsor of this webinar, Bristol Myers Squibb. We have callers from 48 states across the United States, as well as patients and caregivers from 14 countries around the world. Access to expert disease information is so important, and we are thrilled to be able to bring you this educational program. We have a wonderful program planned for you today, and I am honored to introduce you to Dr. Justin Klein. Dr. Klein is a hematologist and oncologist with the University of Chicago Medicine, where he specializes in treatment of patients with Hodgkin and non-Hodgkin lymphomas. At the University of Chicago, he is also an associate professor and a member of the Committee on Immunotherapy and Committee of Cancer Biology. His research interests include development and use of immunotherapies in lymphoma treatments and CAR T-cell therapy. Thank you so much, Dr. Klein, for speaking at our webinar today. Dr. Klein, I will now turn the talk over to you.
Great. Thank you so much, Cecilia, and thanks to all the callers for joining us this afternoon, at least afternoon here in Chicago where I'm at. I hope you're all doing well. So my goal over the next 30 or 40 minutes is to update you all on the use of immunotherapy in the treatment of lymphoma. And as a bit of an outline, I think it's hard to understand how immunotherapy works if we don't understand, at least to some degree, how the immune system works. So I'm going to talk about what I call the nuts and bolts of the immune system and how the immune system is able to recognize and attack cancer cells. I'll move on to talk very briefly about how cancers escape the immune responses that are sometimes generated against them. We'll talk about the different types of cancer immunotherapy, particularly those that are used in the clinic in treating lymphoma. And then finally, we'll talk about some of the clinical results of immunotherapy as it pertains to lymphoma. And so a little bit of a primer on the human immune system. The immune system evolved to provide us protection against pathogens. And what I mean by pathogens are microorganisms like viruses and bacteria. Immune cells, like other blood cells, develop in the bone marrow from bone marrow stem cells. And the immune system consists of immune cells and the proteins that they make, whose purpose it is to recognize and kill those microorganisms. The immune system, interestingly, is educated to be able to recognize and attack foreign invaders, again, bacteria and viruses, but at the same time leave our healthy tissues unharmed. Now, cells of the immune system are sometimes capable of recognizing and killing cancer cells, and these are mainly T cells of the immune system that I'm going to talk quite a bit about in the coming slides. Now, the immune system can be divided in a number of ways, but I think the most useful way to divide the immune system is into two main branches. There's the innate immune system, and these are the cells of the immune system that provide the initial response against a tumor or against an infection. And then the adaptive immune system, and these are the cells of the immune system that really provide a specific and tailored attack. And this response or this attack typically follows the initial response by the innate immune system. Now, as I mentioned a moment ago, immune cells develop in the bone marrow from the hematopoietic stem cell or the bone marrow stem cell. And there are, as I mentioned, innate immune cells, and these are cells, notably macrophages, for example, which are very good at eating cancer cells and infected cells. And then there are adaptive immune cells, specifically B cells and T cells. And interestingly, each of these cells has a very specific protein receptor on its surface that really accounts for the broad repertoire of our immune system and its unique ability to be able to recognize a very wide spectrum of different bacteria and viruses, and sometimes tumor cells. And B cells and T cells do this a little bit differently. But again, these are cells of the adaptive immune system, and they provide that very specific or tailored attack against infections and tumors. Now, because T cells are very important, perhaps the most important cells in the immune response against cancer, I thought I'd talk a little bit about how T cells recognize their targets. And so the cartoon you see really highlights the two different types of T cells. On the lower left, you have the cytotoxic T cell. This is also known as a CD8 T cell. And these T cells are very good at recognizing and killing their targets when they recognize a target cell, for example, that's been infected or that looks a little bit unusual, such as a tumor cell. Now, helper T cells on the bottom right are also known as CD4 T cells. And these T cells, when they recognize their targets, rather than killing them, they typically provide and secrete factors that help CD8 positive T cells grow and become activated. Now, T cells, whether they be CD8 or CD4 T cells, express a very unique protein called the Tcell receptor. And each T cell, very interestingly, has its own unique receptor. And again, that accounts for the broad diversity of the immune system. Now, the T cell receptor recognizes parts of proteins in infected cells or tumor cells, and these little parts or fragments of proteins are called peptides. These peptides are loaded onto molecules called MHC molecules that you can see sort of in the middle of the picture, and the interaction between the T cell receptor and the MHC molecule and the peptide that it holds is really the way that T cells surveil our bodies for evidence of cells that have been infected or cells that have become malignant, because those peptides look a little bit different in infected cells or malignant cells than they do in normal cells. And when the T cell receptor recognizes those MHC molecule peptide complexes, it becomes activated, it grows and divides, and it secretes proteins and other factors that lead to the death or killing of the target cell, which in some cases could be a cancer cell. Now, we all know that cancers are derived from our own tissues. Lymphomas in most cases are derived from normal healthy B cells. And I told you earlier that the immune system is supposed to leave our own cells and our own tissues alone. But it turns out that cancer cells, because of the mutations that they acquire in their DNA, have proteins that look slightly abnormal, and the peptides that come from those proteins after they've been broken down also look just a little bit different than they do in normal healthy cells. And that's how T cells are sometimes able to see cancers or cancer cells as looking just a little bit off, and that's enough to trigger them to become activated and to kill. And so knowing then that at least in some folks, immune cells, and particularly T cells, can recognize cancer cells and kill them, well then why is cancer a problem if the immune system can recognize and handle it? Well, it turns out that tumors, including lymphomas, are very effective at activating pathways that are meant to suppress any immune response that's generated against them. And they do this by recruiting suppressive immune cells, by secreting factors that shut down the function of immune cells, and by increasing the expression or the presence of proteins on their surface that also shut down the function of T cells. And the most important one of those proteins is called PD-L1, and you can see it in red in the upper left hand of this cartoon, being expressed on the top of the tumor cells. And this is a very important protein because the pathway that it's involved in can be targeted and is targeted by a very commonly used immunotherapy that I'm going to talk about in just a moment. And so knowing then that cancers are very sneaky and effective at suppressing immune responses or escaping or evading immune responses generated against them, what we found in the clinic is that reversing these pathways or blocking or inhibiting these pathways can be very effective in restoring an immune response against a cancer, including lymphoma. Now, cancer immunotherapy, or in other words, therapies that make use of the immune system to fight cancer, is not a new concept. It's been around for well over 100 years. However, it's not been probably for more than about 10 years now that we've begun to develop truly effective cancer immunotherapies in the clinic, immunotherapies that lead to cancer regression or shrinkage. And in 2013, the very famous journal Science named cancer immunotherapy as the breakthrough of the year. It's also important to know that a couple of Nobel Prize winners have won the prize based on their discovery of immune therapies that have really revolutionized the way that we treat cancer. And I'm going to talk about those now. Now, there are many different flavors or types of immunotherapy. I'm going to talk about those that are relevant to lymphoma. The first type of immunotherapy that was tested for lymphoma were what are called cancer vaccines. Unfortunately, in lymphoma, as well as in many other cancers, vaccines to treat cancers that have already developed have not been terribly effective in a large fraction of patients that receive them. We all know now of the HPV vaccines that are very effective in preventing cancers, cervical cancers and cancers of the head and neck. But vaccines used therapeutically once a cancer has developed have generally been less successful. There were vaccines called anti-idiotype vaccines that were used and tested in follicular lymphoma in the 90s and early 2000s. They were effective in a small subset of folks, but most people did not benefit from them, and they're really not longer being studied in the clinic. The second main type of immune therapy that's commonly used today in the clinic is called immune checkpoint blockade therapy. The first type, and probably the most widely used type across cancers, including lymphoma, is something called PD-1 blockade therapy. And this type of therapy has been FDA approved now for treating some lymphomas, and I'll talk about this more in detail in a moment. The other immune checkpoint blockade therapy is called CD47 blockade therapy, and this is a therapy that's very exciting, but still under investigation in the treatment of certain types of non-Hodgkin lymphoma. These are called immune checkpoint blockade therapies because the medicines that are given to the patient interrupt important checkpoints, if you will, in the regulation of how the immune system and cells of the immune system do their jobs. And I'll talk more about that, as I mentioned. The third type of immunotherapy that's used for lymphoma is called adoptive T-cell therapy, and in lymphoma, more specifically known as chimeric antigen receptor, or CAR T-cell therapy. And this is a type of therapy where one's own T-cells are genetically modified or engineered to express a receptor that allows them to be able to specifically recognize a protein on lymphoma cells called CD19. And when that recognition occurs, the T-cell becomes activated and kills the lymphoma cell. There are now currently two CAR T-cell products that are FDA approved for the treatment of certain Bcell non-Hodgkin lymphomas. So we talked a little bit about the use of PD-1 blockade therapy in cancer, and this is probably the biggest breakthrough in human cancer treatment, I would say, in the past 20 years. And this is the pathway, and I'm going to explain it to you briefly to help you understand how this therapy works. You can see on the left is a T-cell that's recognizing, imagine a lymphoma cell, through its T-cell receptor, or TCR, by way of an antigen or a peptide antigen that's being displayed on the surface of a tumor cell. When that interaction occurs, the T-cell becomes stimulated or activated. It secretes soluble factors or cytokines. The most famous one is called interferon gamma. As the T-cell becomes activated, it also upregulates a receptor or a protein called PD-1 or programmed death 1. And that interferon gamma that's also made by the T-cell causes the tumor cell to also upregulate a ligand called programmed death ligand 1. And when these two proteins interact with one another, that signals the T cell to shut down, to stop doing its job. And so this is a very famous and common way that tumors use to shut down T cell responses that are generated against them. Now imagine if you could block the interaction between PD-1 and PD-L1, say with a medicine or an antibody, then you might be able to restore the function of that T cell and allow it to continue targeting and killing tumor cells. And so this is yet another cartoon that sort of depicts how this checkpoint blockade therapy or PD-1 blockade therapy works. You can see on the bottom representative of a tumor cell that's expressing that PD-L1 or programmed death ligand 1 protein, which is interacting with the PD-1 receptor on the T cell. And then you deliver through the blood an antibody called an anti-PD-1 or a PD-1 blocking antibody there on the left. And that prevents the interaction between PD-1 and PD-L1, again, restoring and reinvigorating the function of that T cell, allowing it to kill the tumor cell. And so PD-1 blockade therapy, as I said, has clearly revolutionized the treatment of many human cancers. And this is a figure that I like to show to depict that not only does PD-1 blockade therapy work in Hodgkin lymphoma on the upper right with the red box, and in a fairly rare form of non-Hodgkin lymphoma called primary mediastinal B-cell lymphoma, it works well in a number of other cancers like melanomas, lung cancers, cancers of the head and neck, cancers of the esophagus and stomach, and so forth. And what each of these graphs is what's called a waterfall plot. And those green bars that go below the line represent the amount of tumor shrinkage that's happened in an individual patient after he or she has received treatment with a PD-1 blocking antibody, in this case, one called pembrolizumab. Whereas the bars that go above the line are patients that did not respond and who had tumors growing. So what you can see specifically in folks that with Hodgkin lymphoma and with primary mediastinal B-cell non-Hodgkin lymphoma, most of the patients have objective tumor shrinkage, meaning their tumors melt away when this PD-1 blocking antibody is delivered. But I think the main point here is that not only is PD-1 blockade therapy effective in lymphoma, it is really effective across a wide variety of human cancers. Now let's talk about the data for PD-1 blockade therapy in classical Hodgkin lymphoma, where it was first tested in the lymphoma setting. And this was a paper from the New England Journal of Medicine published by Steve Ansel and colleagues. This was a very early phase or phase 1 study of a PD-1 blocking antibody called nivolumab. And this was used in about 23 patients with relapsed and refractory Hodgkin lymphoma, most of whom had had a prior stem cell transplant and another very effective drug called brentuximab vedotin. So a resistant population of patients who had seen on average about 4 therapies before they received the nivolumab. You can see on the bottom right from the waterfall plot that 87% of patients treated with nivolumab had tumor shrinkage greater than, I think, 30%. Importantly, the remissions or the responses that are induced by nivolumab, by PD-1 blockade therapy, tend to be fairly durable, meaning they're long-lasting. About 86% of patients who had been treated with this antibody, this PD-1 blocking antibody, were still in remission 6 months after their treatment. The other nice thing about PD-1 blockade therapy is that, number one, it's easy to use. It's administered through the vein every 4 to 6 weeks, depending on which drug you're using. There are 2 that are approved. And there are a few serious side effects. The side effects that do emerge tend to be mild and tend to be caused by nonspecific activation of the immune system, which can cause inflammation in the skin, causing a rash, or the gut, causing some diarrhea. But the good news is that these side effects are rarely severe or life-threatening. So not only is PD-1 blockade therapy effective in Hodgkin lymphoma, but it's also safe. Now, primary mediastinal B-cell lymphoma is, I would say, what you would call a first cousin of diffuse large B-cell lymphoma, the most common type of non-Hodgkin lymphoma. Primary mediastinal B-cell lymphoma is pretty rare. It tends to develop in the chest area of young people. And it has a pretty good outcome with chemotherapy, but in the patients that for whom chemotherapy fails, we didn't have a lot of good strategies to put them back into response. It turns out that another PD-1 blocking antibody called pembrolizumab is very effective in treating patients with relapsed and refractory primary mediastinal B-cell lymphoma. In other words, patients that have gone through a number of prior treatments. Here, the response rate to this PD-1 blocking antibody, again called pembrolizumab, is about 45%. So about 5 in 10 patients that are treated with this antibody will have significant tumor shrinkage, which is really exciting. And so based on these and other clinical trials that have been performed and completed, PD-1 blockade therapy is now approved for classical Hodgkin lymphoma as well as primary mediastinal B-cell lymphoma. These medicines have been tested in a number of other types of non-Hodgkin lymphoma, including diffuse large B-cell lymphoma and follicular lymphoma. Here, though, the responses and the activity or effectiveness is not quite so clear. Some of these studies are ongoing, but it's clear that particularly in diffuse large B-cell lymphoma, we see about 10 to 15% of patients responding to this type of PD-1 blockade immunotherapy. Now, let's talk about another immune checkpoint and another immune checkpoint immunotherapy that is really directed at activating other immune cells called macrophages. And these are the cells that eat infected cells and eat cancer cells. So these are cells of the innate immune system, again called macrophages. One of their jobs is to recognize cancer cells for what they are and eat them, in other words, kill them. Now, tumor cells, including lymphoma cells, sense the presence of macrophages within the environment of a lymphoma, where the lymphoma grows. And in order to prevent their engulfment or being eaten by the macrophage, they put a protein on their surface called CD47. And when CD47 binds with its partner called Serp alpha, and the names aren't important to remember, by the way, when that interaction occurs, the tumor cell or the lymphoma cell sends a signal to that macrophage saying, hey, don't eat me, leave me alone, I'm fine the way I am. And so the macrophage then leaves that tumor cell alone, which is not, of course, what we want. Now, therapies have been developed to, again, like PD-1 and PD-L1, to inhibit or interrupt interactions or binding of CD47 with Serp alpha. And when that happens, the macrophage doesn't receive that don't eat me signal and says, all right, it's lunchtime, it's time to eat some lymphoma cells. And so that's how this pathway works. Now, like antibodies that block PD-1, the PD-1 receptor, there are antibodies in the clinic that block that CD47 receptor on lymphoma cells, and by doing so, allow those macrophages in the lymphoma environment more access and a better appetite to eat lymphoma cells. And so it's a pretty nifty type of immunotherapy. This is still in clinical trials. The drug that's furthest along is called magrolimab, and this is a CD47 blocking antibody that's given in combination with rituximab, which I'm sure many of you have heard of. And it's been tested in patients with relapsed diffuse large B-cell lymphomas and relapsed follicular lymphomas. And you can see in the table on the lower left, the response rates in patients that are treated with this 47 blocking antibody, in other words, magrolimab and rituximab, are as high as about 50%. And again, in a very tough to treat population of patients, many of whom have had on average 4 or 5 prior treatments before the CD47 blockade therapy. And so, you know, these clinical trials are ongoing, but I think this study that was published in the New England Journal, and we participated in this study at the University of Chicago, indicates, as shown on the PET scan pictures on the right, that simply activating macrophages and their ability to eat lymphoma cells can be extremely effective in the immune treatment of certain types of lymphoma. Now, let's move on and talk about CAR T-cell therapy, which I'm sure many of you have heard of. It's gotten a lot of press over the past 3 or 4 years. And CAR, again, stands for chimeric antigen receptor. And this is a type of treatment that involves the collection of immune cells from the patient from the blood of the patient, and specific immune cells called T cells, as I've been talking about, are engineered to express this chimeric antigen receptor. And the reason it's called chimeric is it's kind of a mix between a B and a T cell receptor, which isn't important. But what this receptor does is it redirects the specificity of that T cell to CD19, which is a protein that's expressed on all non-Hodgkin lymphomas as well as on normal B cells. So in other words, here we're using a fancy trick to make the T cell be capable of recognizing a protein that's on the top of lymphoma cells, and when that recognition occurs, the T cell is triggered to kill that lymphoma cell. So it's pretty nifty. Now, there are currently 2 FDA-approved CAR T cell products for use in certain types of B-cell non-Hodgkin lymphoma. The first is called Bcell. You can see the full name there. It's pretty tricky to pronounce. We call it Bcell for short, and this is made by Gilead Kite. This was the first CD19-directed CAR T-cell therapy approved to treat aggressive relapsed lymphomas, including diffuse large B-cell lymphoma, high-grade B-cell lymphomas like your double-hit lymphomas that I'm sure many of you have heard of, primary mediastinal B-cell lymphoma, which I touched on earlier, as well as transformed follicular lymphomas, or follicular lymphomas that have become more aggressive. This was approved, it's coming on about 3 years ago now. And then the second product, is called Tcell, and this is a CAR T-cell product that's made by Novartis. It also is a CD19-directed CAR T-cell product that's approved for similar indications, including diffuse large B-cell lymphoma, high-grade B-cell lymphoma, and transformed follicular lymphoma. This was approved about 6 or 7 months after Bcell, and these are both used widely in the clinic in the United States and in many areas across the world. So how does CAR T-cell therapy work? Well, it's a bit of a complicated process. As I mentioned, first, the immune cells from the bloodstream need to be collected through a procedure called a leukapheresis, where the blood is taken out. It's filtered through a special machine that isolates the white blood cells, or the immune cells, from the bloodstream and returns the rest of the blood to the patient. Those immune cells obtained from the bloodstream are then sent to a company for manufacturing. T cells are specifically isolated, and a virus actually is used to get that CAR T receptor inside the T cell and get it expressed on the surface. At the same time, those T cells are activated and grown up to very, very large numbers. And this process takes about somewhere between 2.5 to 4 weeks to do. Meanwhile, the patient waits, and before the CAR T cells are reinfused, he or she receives a few days of chemotherapy. And the purpose of the chemotherapy is really to condition the body such that when the CAR T cells are reinfused into the patient, they are better able to expand and become activated and survive for long periods of time. Once that chemotherapy is completed, the patient gets a couple of days off, and then the CAR T cells are thawed and reinfused into the bloodstream. And like homing pigeons, they traffic to sites where the lymphoma is growing in the person's body, recognize that CD19 protein on top of the lymphoma cells, and kill them. Now, the advantages of CAR T cell therapy are that it's a one-time infusion. It can be universally applied because nearly all non-Hodgkin lymphomas have the target, or CD19. That being said, CAR T cells can be manufactured to recognize almost any target on cancer cells, and that's exactly what's being done as we speak today in laboratories and clinical trials around the world. The CAR T cells can be manufactured relatively quickly, and once they're infused into the patient, they tend to grow rapidly and kill lymphoma cells quite quickly and efficiently. And finally, CAR T cells can persist in one's body for months after they've been infused. And so in case a lymphoma has any idea of coming back, there are CAR T cells that are still around that can recognize those lymphoma cells and kill them, even months after they were initially put in the body. Now, what about the effectiveness of CAR T cell therapy in these aggressive lymphomas? Well, it's fairly similar I've highlighted in the red box the important numbers that you might keep in mind, but about a third of patients that are treated with Axi-cell or Tcell achieve a durable complete response, which means that after the CAR T-cell therapy has been delivered, they are in a complete remission, meaning a negative PET scan at 6 months. And when that happens, it's very uncommon for the lymphoma to return thereafter. So about a third of patients that are treated with CAR T-cell therapy seem to have durable remissions. Now on the right column, you see another product called Bcell, and this is another product that's also CD19-directed CAR T-cell product that's being made by another company. This one has gone through clinical studies and is pending FDA approval. So soon we may have 3 different CAR T-cell choices for patients with relapsed and refractory aggressive B-cell lymphomas. And so what I'm showing on the top is the percentage of patients that remain in response after treatment with Axi-cell. And this is taken from the ZUMA-1 study, which was published in the New England Journal of Medicine about 3 years ago now. And what you can see is that for patients who do achieve complete remissions, those remissions tend to be quite durable. And on the bottom, I just thought I'd show you a personal example of a patient that I treated, a young person with primary mediastinal B-cell lymphoma. You can see the very bright enlarged tumor in the middle of her chest, as well as some abnormal activity in the abdomen as well. This young woman received Axi-cell, and the next PET scan was taken about 4 weeks after her CAR T-cell infusion, and you can see her PET scan has gone completely negative or normal. And this is now about 2.5 years ago. She's now back to work, feeling great. You would never know she had a lymphoma looking at her now. So it can lead to very remarkable responses. Unfortunately, CAR T-cell therapy also is associated with some toxicities, some of which can be pretty severe. The unique side effects that occur after CAR T-cell therapy include something called cytokine release syndrome, or CRS, as well as neurological toxicities. Now, the cytokine release syndrome results from a release of proteins that are called cytokines, and these are immune system growth factors. And these proteins or cytokines are released from the activated CAR T cells themselves, as well as from other immune cells in the person or the patient's body. And the release of these factors can lead to symptoms such as fever, which obviously is very mild, or even life-threatening side effects like low blood pressure or shortness of breath from fluid in the lungs. Fortunately, we have a pretty good antidote for this. It's a medicine called tocilizumab and another one called rituxan that can be given along with steroids like prednisone or dexamethasone, which many of you have heard of, in case the cytokine release syndrome becomes more severe. Now, the neurological toxicity tends to occur a little bit later than the cytokine release, and cytokine release syndrome tends to occur about 2 to 4 days on average after the CAR T cells are put in. The neurological toxicity tends to occur about 4 to 7 days after the CAR T cells have been infused into the body. And again, like cytokine release syndrome, neurological side effects can be mild, little headache, little hand tremor, little trouble finding the right word to use in a sentence, or even severe things like seizures, brain swelling, which can occur in a small minority of folks who are treated. Now, because we have gained more experience with CAR T-cell therapy over the past 3 years or so, we're now able to better recognize cytokine release syndrome and neurotoxicity more quickly and to treat them more effectively than we were. And so these are still issues that are around CAR T-cell therapy, but issues that are typically pretty well managed. Now, cytokine release syndrome, I mentioned on the last slide the cause, but this is a syndrome that can affect almost any organ system, most commonly general things like fevers, but people can get skin rashes, nausea, diarrhea, shortness of breath or cough, low blood pressure, swelling, thinning of the blood, or inflammation in other organs like the kidney or liver. Okay. And neurological toxicity, which I talked about some of the symptoms, I thought it would be interesting to show you an example of some handwriting of a patient who developed neurological toxicity. You can see very nice handwriting 4 days after CAR T-cell therapy. On day 5, it looks a little sketchy, back to normal a little bit by day 6. And so because we know that neurological side effects can occur, patients are given very in-depth and careful neurological and mental status exams by the bedside nurse, sometimes as often as every 8 hours following CAR T-cell therapy, to look for these changes that can occur. And so finally, and to allow plenty of time for questions, I'll conclude by saying that the immune system, I hope I've convinced you, is capable of recognizing and killing cancer cells, including lymphoma cells. Now, although immune responses are often generated against lymphomas, they are often suppressed and ineffective because of those pathways that cancers activate to suppress the immune system. We talked about the types of immunotherapy that we use for lymphoma, including CAR T-cell therapy, and then checkpoint blockade therapy, either with PD-1 blocking antibodies or CD47 blocking antibodies. PD-1 blockade therapy works quite well in Hodgkin lymphoma and in primary mediastinal B-cell lymphoma. It's easy to administer and relatively safe. Now, CD47 blockade therapy works in diffuse large B-cell lymphoma and follicular lymphoma. It's also very easy to administer and well tolerated in general by patients that receive it. CD47 blockade therapy is not yet approved for use in lymphoma and is still undergoing clinical trials, but hopefully someday it will be. And then finally, we talked a bit about CAR T-cell therapy and the fact that it can induce or lead to long-term remissions in patients, but it is expensive and can be associated with some potentially severe side effects. And so with that, I'd like to thank you all for listening to the presentation, and I'd be delighted to answer any questions that you may have. Thank you so much.
Thank you so much, Dr. Klein. We really appreciate you joining us today.
My pleasure.
Before we open the program up to questions, I want to share some information with you on the Lymphoma Research Foundation that may be helpful to you as you navigate lymphoma and long-term survivorship. The Lymphoma Research Foundation is the nation's largest nonprofit dedicated exclusively to lymphoma. Our mission is to eradicate the disease through investment in the most promising lymphoma research and to serve those impacted by lymphoma through quality education and support opportunities. As we continue to make progress in advancing lymphoma research, we also want to ensure that you have access to the latest information about your disease. The Foundation provides comprehensive disease and treatment-specific resources, programs, and services, all of which are offered free of charge and have been reviewed by lymphoma experts. Most relevant to today's call, LRF offers a variety of lymphoma-specific resources, many of which you can access at the bottom of your screen if you are utilizing the web link or via LRF's website at lymphoma.org if you are on your phone. First, I want to talk about the LRF helpline. The helpline can answer your specific questions about lymphoma as well as discuss relevant treatment options and clinical trials. We also offer the Lymphoma Support Network, which is a one-to-one peer support program for people with lymphoma and their caregivers. The Lymphoma Support Network connects patients and caregivers with volunteers who have similar experiences to help give others strength to meet the challenges they may have to face. We also offer a variety of publications that have been reviewed by lymphoma experts to ensure you have access to the latest lymphoma information. We have comprehensive books on understanding non-Hodgkin lymphoma, Hodgkin lymphoma, chronic lymphocytic leukemia, and the transplantation process. We offer a variety of easy-to-understand fact sheets on each of the subtypes of lymphoma, as well as supportive care topics and immunotherapy that may be relevant to your lymphoma experience. Our mobile app, Focus on Lymphoma, is an award-winning app that provides patients and caregivers access to comprehensive content, as well as unique tools to help manage your disease. The app is available for free download in the Apple App Store and in Google Play. Finally, we have launched our COVID-19 Learning Center to support lymphoma patients and caregivers through this challenging time. Please visit our Learning Center for access to webinars, articles, and other resources specific to COVID-19. I really hope that you all will take advantage of some of the great resources and services that the Lymphoma Research Foundation provides. If you have questions regarding what you have learned today, or need information about relevant treatment options, you can reach out to the Lymphoma Research Foundation through our website at lymphoma.org or by calling our helpline at 1-800-500-9976. Thank you all again for your time today. We will now begin our Q&A portion of the program. Just as a reminder, please keep your questions as general as possible so that the entire audience can benefit from their answers. If you would like to ask a question, please submit your question through the Q&A box on your screen. We will take as many questions as possible, but if you have a question that does not get answered, you can always reach out to the Lymphoma Research Foundation's helpline at 800-500-9976. And now we have our first question from online. My insurance company approved treatment with a biosimilar drug, rituxan. If possible, I would like to know your opinion, Dr. Klein, on biosimilar drugs being used for lymphoma treatment.
Yeah, so that's a good question. I think I don't want to speak to biosimilars in general, although I think largely they do recapitulate the safety and efficacy or effectiveness that their originators have. I think with the rituximab biosimilar, I am totally comfortable using it. The efficacy data support that it is equivalent to rituximab. So I wouldn't worry about that at all. You're getting a good therapy with that biosimilar in particular.
Great. Thank you very much.
Mm-hmm.
Our next question is, how many patients are receiving these CAR T-cell? Why is it only used with relapse if there are durable results?
Good question. So, I don't know the numbers of patients across the world that are receiving CAR T-cell therapy each year. I would speculate these days it's in the thousands. Even though CAR T-cell therapy can induce durable remissions in, as I mentioned, about a third of folks that receive it, you have to remember that for diseases like diffuse large B-cell lymphoma, for example, we know that standard treatment with chemotherapy and rituxan, R-CHOP, for example, is able to cure upwards of 60 or 65% of patients. And so as it stands now, the initial treatment that we have for diseases like diffuse large B-cell lymphoma is pretty effective. Now, it's not perfect, but it's pretty effective. And so I think it's going to be hard for therapies, even therapies like CAR T-cell therapy, to move up into the frontline setting because, again, unlike many other cancers, in lymphoma, we have some pretty good treatments that have been developed, over the past several decades. There are clinical trials, however, looking at whether CAR T-cell therapy, now approved in third treatment and beyond, is effective as the current second treatment for relapsed aggressive lymphomas like diffuse large B-cell lymphoma, which is chemotherapy and stem cell transplantation. So there are a couple of clinical trials that are randomizing patients to CAR T-cell therapy or chemotherapy and transplant. And I expect that we'll have the answers to those questions soon. So we may find that CAR T-cell therapy moves into the second line of treatment rather than or replacing chemotherapy and stem cell transplantation.
That would be great. Thank you, Dr. Klein.
Mm-hmm.
Our next question is, can more than one CAR T be engineered for improved efficacy?
Yeah, that's another good thought, and folks who are doing research in this area are trying to do exactly that. We know that in lymphomas, CD19 has been kind of the primary key target for most CAR T cells. B cells, healthy B cells, and lymphoma B cells typically express other targets like CD22, CD20, to name a couple. And so the question is, what if we came up with a CAR T cell that could recognize multiple targets? Would we have less recurrences after that therapy is delivered? And there's no answer to those questions as it stands. But those new types of CAR T cells are being evaluated across the world in many, many clinical trials. It's just too early to know for sure.
Great. Thank you. Our next question, has CAR T-cell therapy been used in clinical trials for CLL and other subtypes? Are any looking promising?
Yes. As a matter of fact, CLL was the first disease for which CAR T cells were utilized in lymphoma. It is very effective. There are a number of studies that are ongoing, and I do suspect that someday, probably within the next couple of years, I would expect the FDA to approve one of the several CD19-directed CAR T-cell therapies for CLL, or its cousin called small lymphocytic lymphoma, or SLL. The issue with CLL, it's not really an issue, it's a good thing, is that there are already a number of outstanding treatments for it that have been developed over the past decade, including drugs like ibrutinib, acalabrutinib, venetoclax, obinutuzumab. And so these therapies work well, and they work for very long periods of time for most patients. So many don't need CAR T-cell therapy. But when we run out of good options, these good options for CLL, that's when CAR T-cell therapy, I think, could come in. So I do think that we will be using CAR T-cell therapy in an FDA-approved way outside of clinical trials within the next few years. Other subtypes of B-cell lymphoma, including mantle cell lymphoma, where CAR T-cell therapy is also very effective and also likely to be FDA-approved probably later this year, are being and or have been examined.
Great, thank you very much.
Mm-hmm.
Are there any immunotherapies that are available for T-cell lymphoma patients?
Yeah, there. As it stands now, the one immunotherapy, and I didn't talk much about it, that is available for folks who have cutaneous or skin T-cell lymphomas is called megamolizumab. And this treatment has been approved for a few years now, and it works by preventing the recruitment of certain cells and inducing their death into the sort of the tumor environment in the skin. And so outside of that, though, the other therapies like PD-1 blockade has not seemed quite as effective in most T-cell lymphomas. CD47 blockade therapy, the data are very limited, but there does seem to be some effectiveness, particularly in skin T-cell lymphomas. So that may be something to look forward to, not FDA approved now. And there are CAR T-cell therapies that are being developed for T-cell lymphomas. The problem is that, what we found from delivering CD19-directed CAR T-cell therapies for B-cell lymphomas is that, these CAR T-cells can't distinguish between a normal, healthy B-cell and a lymphoma B-cell. And so patients that receive these CAR T-cell treatments often have very low B-cell numbers and, as a result, very low antibody levels for years and years, which can lead to infections. But the antibodies that are made by B-cells can be replaced by transfusion. On the other hand, when you kill normal T-cells, that really sets a patient up for infectious complications, which has been really the main limitation of CAR T-cell therapy for lymphomas that are derived from T-cells. So down the road, I suspect we probably will have some CAR T-cell therapy available for T-cell lymphomas, but I suspect that's a few years away yet.
Okay, great, thank you.
Mm-hmm.
Our next question is also from online. For patients that have had an adverse reaction to rituxan, what alternative immunotherapies are there besides Gaziva? And can you talk about how often these are used?
Yeah, so, infusion reactions to rituxan, or, the chills and shakes and chest pain and shortness of breath that can sometimes develop, and I suspect that some of our listeners have experienced, are pretty common. And so before I give up on rituxan, I really want to be sure, number one, that the patient is truly intolerant of rituxan, and number two, that we make sure we give it the old college try with a lot of pre-medication with steroids and Tylenol and Benadryl before giving up. The problem, even in my practice, has been that for patients who have recurrent severe rituxan reactions, I'm very hesitant to administer similar treatments like obinutuzumab or ofatumumab that work the same way as rituxan, because you never know if the reactions are going to occur similarly. And so the availability of other immunotherapies like the PD-1 blocking antibodies, nivolumab or pembrolizumab, would really depend on the particular subtype of lymphoma that the person was dealing with. So it's difficult to answer that in sort of a blanket way. But I think for most patients, what we're left with is either giving chemotherapy, for example, CHOP or bendamustine without the rituxan or similar, or coming up with a completely alternative targeted therapy that is given without rituxan. That's a tough one to deal with.
Absolutely. Thank you. Are there any advancements in immunotherapy for Hodgkin lymphoma?
Yeah, so Hodgkin lymphoma is really, this is really a lymphoma that is characterized almost universally by huge infiltration by the immune system and immune cells, and this is the prime model for how immunotherapy, particularly PD-1 blockade therapy, can work. And initially, I talked about the initial study of PD-1 blockade therapy in Hodgkin lymphoma, where it was given to folks with very advanced resistant disease. Other more recent studies have combined immunotherapy with PD-1 blocking antibodies, nivolumab or pembrolizumab, in the second line of treatment, and are even being explored now in a very large study in combination with chemotherapy that's typically used to treat Hodgkin lymphoma. So I think in the future, we're going to see PD-1 blocking antibodies like nivolumab and pembrolizumab given earlier in the course of the disease, and thereby allowing us to omit some of the chemotherapies that we typically have to give patients. So look for more. I think we're going to find that PD-1 blocking antibodies are going to be widely used, at least in the second line of treatment, potentially even as the initial treatment that we're using for Hodgkin lymphoma.
We'll definitely be on the lookout. Thank you. Our next question is, why has CAR T-cell therapy been limited in treating aggressive and transformed lymphomas?
Well, when you say limited, I'm going to talk from the perspective and presume that what you mean is limited in the fact that it doesn't work for everyone, or that not everyone is a good candidate for it. And I'll talk about those separately. First, in order to receive CAR T-cell therapy, you have to be, the person has to be in relatively good physical condition, because the side effects can be pretty severe. And so not everybody who's been treated time and again for lymphoma is in proper shape to receive CAR T-cell therapy, or they have other health problems such as heart problems or lung problems that wouldn't let CAR T-cell therapy, or wouldn't allow CAR T-cell therapy because of safety concerns. Now, as far as why doesn't it cure everyone, that's a great question to which I don't have all the answers. We know from some patients who recur or have relapses after CAR T-cell therapy, sometimes the lymphoma cells are sneaky and they lose the target. CAR T-cell therapy only works if that CD19 protein is displayed on the top of the lymphoma cell. And if a lymphoma cell acquires a mutation that allows it to survive and grow without CD19, then CAR T-cells are completely ineffective. And we know that this is a fairly common reason why CAR T-cell therapy fails. In other patients, it's less clear. Sometimes the CAR T-cells are infused and they work for a brief period of time, but then they die off. They don't survive to the point at which the lymphoma is gotten rid of completely. And so the lymphoma eventually comes back. And then in other patients, we imagine that for one reason or another, which we don't understand, the CAR T-cells simply don't get into the lymphoma tumors as well as they should. And if they don't get into the tumor, they can't do the job they're meant to do, which is to kill lymphoma cells. So those are I think the three most common reasons for failure. Number one, loss of the target by the cancer cell, failure of the CAR T cells to survive and grow after they've been put back into the person's body, And 3, the CAR T cells simply don't traffic or get into the lymphoma in order to do what they need to do. So I hope that answers the question.
Definitely. Thank you very much. Circling back to what you had spoken about PD-1 therapy, can a PD-1 therapy be used for patients who relapse after ABVD therapy instead of a stem cell transplant? Is it possible to avoid a transplant with the use of immunotherapy treatment?
Yeah, that's a good question. A physician and Hodgkin lymphoma expert called Alex Herrera at City of Hope is hoping to initiate a study to ask exactly that question. Currently, stem cell transplant is kind of the standard second treatment for Hodgkin lymphomas that either failed to go into remission with ABVD or that recurred afterward. And that's been the standard for many years now. Now, he and his colleagues performed a study of the PD-1 blocking antibody called nivolumab combined with another effective drug in Hodgkin lymphoma called brentuximab vedotin. And this cocktail, these two treatments, worked extraordinarily well to induce remissions. And the goal, of course, of the study was to get people to transplantation without, to get people to a complete remission so they could go on to stem cell transplantation without the need for conventional or old-fashioned chemotherapy and the side effects that come with it. But it turns out that a number of patients decided not to go on to transplant for one reason or another. And some of these folks have very durable remissions. And so the study that he's going to be opening up probably in the next 6 to 12 months is going to ask that question for patients who receive nivolumab and brentuximab. Do we always need to proceed to transplant? So these patients who achieve good responses are just going to be watched rather than transplanted. And we'll see how things go. And so the answer to the question in short is we don't know yet. But I think that's a question that hopefully we'll have answered in the next few years. Currently, though, stem cell transplant is still sort of considered the standard of care.
Great. Thank you very much.
Mm-hmm.
What factors are taken into consideration when deciding between rituxan and Gaziva for treatment?
Yeah, so they both rituxan and obinutuzumab or Gaziva, they work the same way. They're antibodies that target a protein called CD20 on lymphoma B cells, and when they do that, that helps the immune system, like macrophages and other immune cells called natural killer cells, recognize and kill lymphoma cells. Both are very effective. They have similar side effects, most notably those infusion reactions I talked about earlier. Gaziva also is a little bit more associated with low white blood count after treatment than rituxan, so it's a little bit more toxic. Now, in follicular lymphoma, there's pretty clear data to suggest that, and probably CLL as well, that obinutuzumab is a more effective antibody than rituximab, and some physicians have changed over from rituxan to Gaziva for that reason. In aggressive lymphomas like diffuse large B-cell lymphoma, there doesn't seem to be an advantage of using Gaziva, also known as obinutuzumab, over rituximab. And so for that reason, in DLBCL, we're still using rituximab. So that's kind of the nuts and bolts of the picture. Because of the increased side effects that can be seen with Gaziva, some docs are still using rituxan over Gaziva in follicular lymphoma and CLL, including myself for the most part. But I do think that it probably is a better therapy, slightly better therapy for those diseases. So higher risk, maybe a little bit higher reward as well.
Great. Thank you very much.
Mm-hmm.
Our next question is, what kinds of side effects do PD-1 blockers have? In other words, how sick do patients feel when on them?
Well, good question. Most patients don't feel sick at all. They're surprisingly well tolerated. Certainly no drug in this line of work is free of side effects. The common side effects that develop in folks that are treated with PD-1 blocking antibodies include things that are common, like fatigue, a little bit of nausea sometimes, some skin rash, sometimes some diarrhea. There are others. underactive thyroid gland or hypothyroidism that sometimes needs to be fixed with a pill. Serious side effects, those requiring hospitalization and treatment with immune suppressive medications like prednisone, are very rare. They're seen in only about 5% of patients, and those tend to be things like bad diarrhea from inflammation of the colon, inflammation of the lungs leading to shortness of breath. You can sometimes, very rarely, see inflammation of other organs that can be pretty severe, like the heart and brain. That's exceedingly uncommon. For the most part, the patients I've treated with, and others have treated with PD-1 blocking antibodies tolerate the treatment very well, and oftentimes much better than chemotherapy, which is why, as I said early in the presentation, that these drugs have really revolutionized the way that we think about how cancers are treated.
Great. Thank you very much. Our next question, are there promising immunotherapies for indolent lymphomas, such as marginal zone or Waldenström's?
Yeah, so that's a good question. These are, as you mentioned, indolent or slow-growing lymphomas, for which we have a lot of effective treatments that have very limited side effects. So for the vast majority of folks with these types of lymphomas, we're able to control and treat these diseases effectively with drugs like rituximab or chemotherapies like bendamustine, or targeted therapies like ibrutinib, without the need for aggressive treatments like CAR T-cell therapy. Now, PD-1 blockade therapy outside of Hodgkin lymphoma and primary mediastinal B-cell lymphoma does not seem to be particularly effective in other forms of indolent or aggressive non-Hodgkin lymphoma. So I don't think it's likely we're going to see approvals for PD-1 blockade therapy in Waldenström's or CLL or follicular lymphoma. I could be wrong, but that's kind of how I see the data now. Now, CD47 blockade therapy, I think it's too early to say. My sense is that it probably would be effective in those indolent lymphomas. And so we know it's very effective in follicular lymphoma. So I have pretty strong reason to believe it's going to be effective in those other lymphomas as well. They're a little bit less common, and so it's harder to do clinical trials in those diseases. But I think that would be one therapy I would keep my eye out on for, that is CD47 blockade therapy.
Great, thank you. Our last question will be another one from online. If a patient fails CAR T-cell therapy, what treatments are then available? Right.
I sort of divide that into when the failure occurs. For patients who have a durable response, meaning over 6 months, over 3 months at least, but generally over 6 months, and then have what we would call a late recurrence, I think that that some of these folks, and I've seen it in my own patients, respond very well to PD-1 blockade therapy. One of the suspected mechanisms by which CAR T-cell therapy fails is thought to be those PD-1, PD-L1 interactions that I talked about. And so for people who have had a really good response with CAR T-cell therapy, it's lost late, I think that PD-1 blockade therapy should be considered. Now, for patients who fail, and of course, if folks get back into remission, then we consider therapies like allogeneic or donor stem cell transplantation. For the subset of patients who fails early, meaning they don't really have a response to begin with after CAR T-cell therapy, that's a tough situation to be in. I have had some luck with a newly or recently approved cocktail of medicines called polatuzumab, bendamustine, and rituxan. I found that it doesn't work for everyone, but I've had pretty decent luck with it in treating the lymphoma back into at least a partial response. And so that's one option. And then I think that's really where clinical trials testing new drugs should be sought after, because that gives the person the opportunity for new drugs in a disease setting where conventional chemotherapies are less likely to be effective. And so that's what I would encourage somebody who's failed CAR T-cell therapy to consider, are clinical trials, and there are many of them going on across the country for aggressive lymphomas.
Thank you very much.
Thank you, Dr. Klein. And we want to thank you again to each of you for joining on today's call. We hope you found the information both informative and also helpful. We'd also like to thank our sponsors again for making this program possible, Bristol Myers Squibb. Please remember, if you have any additional questions or would like to be connected with someone else who has been impacted by lymphoma, you can reach out to the LRF helpline at 800-500-9976. Once again, that's 800-500-9976. Also, at the conclusion of this program, you'll receive an email prompting you to complete a program evaluation. I would ask that you please take a few moments to complete this brief evaluation, as these are important for helping LRF to ensure that they deliver the most useful and meaningful programming to you. And with that, I'd like to thank all of you again for joining us, and everyone have a wonderful day.